Welcome to the Valaura Exchange, where leaders connect the dots between health, humanity, and performance. Each episode brings real conversations, fresh perspectives, and the insights shaping the future of how healthcare leaders understand and solve today's most pressing challenges.
Well, medication adherence has been one of healthcare's most persistent challenges. Even with advances in predictive models and population health strategies, adherence rates remain surprisingly low. As we approach World Adherence Day, it's a good moment to ask why this problem has proven so difficult to solve. I'm Theresa Connelly, and I'm the Clinical Director of Business Development here at Valaura Health, and I also have my Chief Clinical Officer here, Ifham Ahmed.
Thanks, Theresa. In our work, adherence is just not a compliance issue, but more of a systemic challenge. We have issues with clinical workflows, patient engagement, and a lot of real-world context. As Theresa mentioned, my name is Ifham Ahmed. I am the Chief Clinical Officer at Valaura Health, and today we're really excited to talk to you guys about this pressing issue.
And actually, we're joined with a special guest today, Philip Morisky. So he's had a lot of work done on medication adherence measurement and also shaped how healthcare systems understand and evaluate adherence. So thank you so much for joining us today. And we're really excited to get started with you and ask some questions if that works. And I actually get the honor to ask you our first question. So if that's good, Philip, we'll go ahead and get started.
Yeah. Thank you. Nice to be here.
Awesome. Well, I guess the first one is, since you have all of your work centralized over medication adherence, and that's something that here at Valaura we're very specialized in as well, why has medication adherence remained as such a persistent challenge despite decades of research?
So I'm Philip Morisky. I discovered a model called Predictive Emergence, and I'm an avid researcher in adherence science. I'm also the steward of the Mariske medication adherence scale that my father, Dr. Donald Morisky, developed across nearly 4 decades of extensive research, from Johns Hopkins to UCLA to international university appointments as a visiting professor, mainly in China and the East. So I'm extending that legacy into behavioral prediction science, where we're going to shift from snapshot adherence, meaning looking at a patient at a specific point in time, to trajectory-focused intervention and what the system around that patient needs to do to support that stability.
That's awesome. And I guess one thing I just wanted to ask, what would you say healthcare systems often misunderstand about adherence? Maybe just from something you've seen in your work when you've either gone on site or just in your overall research?
Yeah, so the MMAS, it provides sensitivity as high as 93%. So that means it could correctly identify most patients who are struggling with taking their medications. We'd rather have a conversation with 10 patients and find 9 out of 10 are fine than miss the one that isn't. Sensitivity prioritizes finding the people who need help. So we want to focus on those people rather than the people who don't need help. When the cost of measuring somebody is hospitalization, you're going to optimize for sensitivity every time. And the thing is, global adherence rates have barely moved. I know in 2003, the WHO has that claim that nearly 50% of patients are not taking their medications as prescribed. So we identify the problem with great precision, but we struggle with interventions when we put that to scale.
Thanks for that background, Philip. Now, you touched on it a little bit, but could you explain to everyone the theory of predictive emergence and kind of why it changes how we view adherence?
Yeah, so the predictive emergence was not developed. It was actually found. From that paradox where we can identify very high, but the interventions are failures, I went looking, and what I found, and it was probably under a huge, heavy rock, is that adherence is not actually a discrete behavior. It was always an emergent property, something that arises from the intersection of 3 forces. Can they do it? Will they do it? And will the world allow that to happen? So I frame that as architecture, execution, and context. And architecture is what has the care system actually built around this patient? The prescription design, the follow-up structure, the support infrastructure, the systems side of the contact. Will they do it? So that's execution. What does the patient actually do with the system that within the system that it provides, their behavior, their consistency, their choices under pressure. So the patient's side of that contract. And will the world allow that to happen? That's context. What life is built around the patient before any clinician ever walks into that room. So you're thinking of housing stability, cultural environment, competing obligations, the forces that none of us prescribe, but all of us are accountable for. And none of those three forces alone predicts what happens. It's an interaction. So that's where the word emergence comes from. It's the emergent property that arises when architecture meets execution inside of a context. So I didn't invent the relationship. It's always been there. I just gave a name and formalized it. And here's what I know that it tells me it's right. It's not a peer review. It was the clinicians. So within weeks of publishing my theory, maybe in early January, I started getting messages from all around the world from researchers saying the same thing. This is the missing link in my own work. I couldn't explain why my interventions weren't translating into outcomes. Now that I can. The theory of predictive emergence, it begins with a simple but powerful premise. Adherence behavior is not linear. You can't predict it by adding up the risk courses. You have to look at how three fundamental dimensions interact simultaneously. So let's visualize like a three-legged stool. You can have the strongest two legs ever built. Think if the third one splits. That stool's not going to wobble. It's going to fall immediately. So we're trained all of our lives that behavior or that care is additive. If two things are going well, it'll compensate for the lack of a third part to it. But in a system, one critical failure is a systems failure. So essentially, it's non-compensatory. And that's why I have as a geometric mean. Predictive emergence is the multiplication of architecture times execution times context. And you cube root it because you want to bring it back to between a 0 and 1. So the non-compensatory thing says whenever any dimension reaches near 0 or 0, the entire score reaches 0. So regardless of how strong the other two are. So that's the whole concept of the three-legged stool. But more importantly, when we put a face to it, I'm thinking of a woman from some data. So full medication access. She understood the medication regimen carefully and completely. Her intent to take medication was genuine and consistent. But by every execution metric, she looked fine. But she was socially isolated. She lived alone. There was no family nearby. There was no one checking in. Transportation to the pharmacy was uncertain on a difficult day. So she had strong architecture and she had strong execution, but her context, which is the third leg, that was close to 0. So the stool was on the floor and the system never saw it coming because every metric that they were tracking looked fine.
Well, the three-legged stool is a great way to kind of visualize it. I've never thought of it that way. Would you say that traditional models then don't have that synergy between the three legs of the stool, or what do you think is missing in traditional adherence models?
Well, like I said, traditional theories add everything up. And like I said, like my example, if two things are going well, then the third one could somehow compensate, or the lack of the third one could somehow compensate. But in a multiplicative concept, that's not going to happen because anything times 0 is 0. And that actually proves in not just medication adherence, but all other domains too. And I've actually pre-tested my theory with things outside of medication adherence. And so far, the data looks very promising. Nothing validated yet, but definitely something to consider.
Awesome. And I guess to add to that, just because I've seen your posts too, how you're going to be speaking for World Adherence Day, you're collecting a lot of data as you speak, right? I know that's something that is part of your project, the World Adherence Project. Would you mind just talking about that in general, just how people maybe can help participate and give back to the research that you founded?
Yeah, no, I'd love to talk about that. That's my present to the world and what I really see adherence going to now and into the future. So the adherence concept or the adherence project was born from the World Adherence Day. And last year, the World Heart Federation coined the inaugural World Adherence Day. And I always had this idea that, from that 2003 WHO report that 50% of the patient's population is non-adherent, I somehow figured, man, that was like 20, 30 years ago. How can we prove that or disprove it now? So I just, am really savvy on the computer, and I've taught myself the code, and I put this small little easy program together. And what it does is populates MMAS scores around the world. So somebody could take the test, the assessment. It's not a test. The assessment in Bhutan, in Jamaica, in America, all at the same time, and it will show up on the map. And that's true population adherence. And I'd love for everybody in the whole world to participate in this week-long event. And I say week-long because World Adherence Day is one celebratory or campaign day out of the year, but adherence is not taking your medication one day. It's not even taking your medication 2 days. It's the consistent act of taking that medication every day measured over time. And that's why this project is going to be a week-long event starting on March 20th, which is this Friday, and going for 7 days, 24 hours a day. And my goal is to get every country represented so we can actually see in real time how adherence looks like per country, per SDOH, and everything in between.
That's awesome. And
No,
I
that's
actually was able to see it too. I saw your post and everything, and I saw the interactive maps. I mean, just being able to track all of that is really cool, but also seeing that it's going to add to more data for us to learn more. And like you said,
And there's a pathway for every student, every researcher, or every patient, or every large pharmaceutical company as well. Students benefit by this can be their first introduction to validated assessment tools for thesis and dissertations. Life science could use it as endpoint measures in a clinical study or trial, and researchers could use it to further their education. Patients benefit not just by giving anonymous data, which is very secure in my platform, but also we're identifying whether they're intentional or unintentional in their non-adherent behavior. So we can actually triage or categorize each patient, whether they stop taking their medications for reasons other than forgetting, because they felt better, or because they felt worse. Because adherence is not just giving them an app reminder and say, hey, every time this alarm goes off, take your medication. Because obviously there's some people who lack the education and saying, this medication is not going to really help me anyway. Why should I take it? Even though they collect their prescriptions on time, they get, timely refills. So from a payer's perspective, this person is adherent. They match that PDC threshold of 80%. Therefore we get a checkbox and everybody gets paid. But adherence isn't really like that. It's actually taking the medication. It's not just having access to that medication.
it's very true. And that's something that we see in our line of work too all the time. And we have to dig deeper, right? Like looking at other angles, reasons, motivational barriers for why they're not taking the medication, for example. But very helpful to hear. And thank you for sharing more about World Adherence Day, because I know we're really excited to keep tracking along with you. And I guess
Yes.
one thing to ask you, because it kind of goes along with what you've already talked about, where do healthcare organizations struggle when translating prediction into improved outcomes, would you say?
So it is a clinical tragedy in our field. We've gotten really good at identifying patients who will be non-adherent. Machine learning, risk stratification, predictive analytics, all the models work. So the identification is accurate. But then we hand that list of patients to a care team and they say, go ahead and intervene. And intervention could be a phone call, a text message, a refill reminder, but they're not categorizing it. So these are execution layer tools applied to an architecture layer problem. So when you look at that, you're giving tools that are targeting the wrong dimension. And that's why the theory of predictive emergence categorizes 3 dimensions rather than just say, these people are not adherent, let's do something about it. When a patient can't afford their medication, a reminder is not going to fix that. When a patient doesn't trust their provider, a phone call from a stranger is probably going to make things worse. So the intervention must match the dimension of instability that flows directly from the stool metaphor that I gave earlier. If the third leg's broken, you don't fix it by pushing harder on the first leg.
That's very fascinating. A lot of the traditional models kind of work how you explained it, right? Patients are risk stratified, interventions done, whether it's phone, SMS, and then hopefully the outcome is improved adherence. But what should healthcare leaders evaluate in their current programs where they're having that synergy between the three domains that you mentioned: architecture, execution, and context? Like, what are they not seeing that's causing that synergy to not happen, in your opinion?
So yeah, so context is probably the least identified with all the current tools in play. Pill caps, MEMS caps, PDC, MPR. Those aren't going to look at how the system around them is or is not helping. Intentional and unintentional adherence. They don't have tools out there aside from subjective measures that could actually listen to that patient's story. And that's what I guess that's the thing that answers your question. We want to include the patient in each and every context as far as intervention. We want their input. So you have the shared decision making, you have collaborative care management, you have all these concepts and tools that are out there. Motivational interviewing, we're really listening to that patient tell their story. And when we open the doors for them and we use, structured tools that could actually ask questions repeatedly, and one place could ask the same question and another place could ask the same question. So you have a benchmark or a baseline that you could compare different dimensions with.
That's really helpful to know. And I think something that I'm sure Ifham, you would agree too, we've come across a lot of these different barriers, having to address them. And like you mentioned, not just maybe one time even, and also making sure it's a continuous feedback loop. I think that was something you sort of illustrated too, right? Making sure we're like learning from the feedback from others so that we can make the system grow smarter, stronger,
Exactly.
like have more inputs.
And feedback from that patient themselves. So you don't just
Absolutely.
observe them, test them once, and then you're out the door. You want to kind of benchmark them, and then have them come back, or assess them. 3 months, 6 months, 9 months later. You want to consistently have the most up to date data that could be in sync with their refill data. So now you have an objective measure and a subjective measure looking at the same thing, and that's how you really correlate adherent behavior and whether they're stable or fragile. And that's also how I really conceptualized predictive emergence. I was really looking for something that could actually measure stability and fragility. So there's a thin line that a patient could be very adherent, and then they lose their job, or a death in the family, and then all of a sudden they fall off the ropes within a matter of days. And there's no other tool out there that could identify ahead of time, can we predict, if this patient is going to be adherent or stable 1 week, 3 weeks down the line. And that's what I'm really focusing on developing here with predictive emergence and the tools that I'm developing based on that theory.
No, that's great. And I think since we have a health plan following for our podcast that we're going to be sending out to everyone, something I was wondering is if you were advising a healthcare plan or just healthcare organizations in general, what should they think and like redesign, if you will, for adherence programs, given like all that you know and what you've shared today with us?
Yeah, so there's probably about 4 consistent patterns that I've seen in the industry. First of all, they skip architecture. So they build beautiful intervention protocols without first asking whether the patient has a stable foundation. Execution tools on a broken architecture do not hold. So they're pushing harder on the one leg when the other leg is missing. Second, they apply the same intervention, like I said, intentional and unintentional. There's no separation between the two. They're intentionally non-adherent patient, it's not going to believe the medication works. They need somebody, a trusted clinical conversation. You can't just have some guy call up on the phone and say, "Hey, how are you doing with your meds?" There's no trust factor built into that. They're sending them a refill reminder, signals that the system doesn't really understand them. They want somebody to educate them. They don't want a reminder. So the third one, they're measuring the wrong outcomes. Like I said, prescription fills are not adherence. Claims data is not adherence. Refill rates, they're not adherence. So these are all administrative proxies. They're not validated. They're just measuring pharmacy behavior, not patient behavior. And the fourth one is probably they design for populations instead of people. Adherence, it's deeply personal. It's a dynamic phenomenon. A patient they're not a risk score. The woman with the broken leg, she never appeared as a high priority in risk stratification because her first two legs looked strong.
I think the big takeaway for me will be what you just said in that last sequence, that a lot of great execution not built on proper architecture. I think that's a huge problem, and thank you for framing it that way. I know a lot of our viewers will also find that very helpful, and it'll be a big important takeaway for them as well. So I just want to highlight that once again. You talked a little bit about all that you're hoping to do across the world, have every country kind of chime in on their adherence and try to make an impact globally. Where do you hope to see adherence change in the next 10 years in your work or worldwide?
So yeah, I'd like the focus to be on adherence, and it really is. Just recently in the World EPA Congress, Servier Pharmaceuticals, one of the very large pharmaceutical company in Europe, one of their persons really high on the executive level used the theory of predictive emergence as a foundational approach in therapeutic adherence management um, in their company. So I'm really excited about that. I had no collaboration with Survey prior to that. They just came across my theory one day, and they really, took hold of it. And I'm excited to see where that's going to lead to.
No, that's
Yeah,
awesome.
to go further into your question as far as what do I see in 10 years, I definitely see students using, tools like large language learning, AI. We have to be careful because we have to keep AI as a co-pilot, not as autopilot. Someone quoted that, and I really latched onto that, and I really found that very meaningful. Um, and with all this data that I can provide and tools that I'm building can provide, I think we should really use that data objectively and really look deeper into what these metrics are showing, because I include a lot of social determinants of health. That's very important to correlate with non-adherence. There's other tools out there that focus on why people aren't adhering to their medications. Mental health, um, what else? Suicide, all these, other factors could come into play as to the reasons why. And the thing with the MMAS, it's a lagging indicator, meaning that it looks at a patient in time and towards the past. We want more predictive analytic tools like predictive emergence that could actually forecast where patients are going to be 3 weeks, 6 weeks down the line, and really focus on how we could fix the system before it breaks. Again, adherence is not a patient problem, it's a systems problem. And we want to all focus on that attitude and really work together. And that's why I collaborate with so many pharmaceutical companies, with students, with universities and hospitals to get these tools out there.
Absolutely. And I've been following your work. So it's been very interesting to see what you have to share with the world. And I know I'm technically on my last question, but I guess I just wanted to see, since you have so much insight, if there was anything else just in general you wanted to share. Otherwise, just trying to find like that punchline, that final guiding principle that we could give to our audience and healthcare leaders alike, just to kind of give them some more wisdom about adherence overall.
Yeah, my father, he spent 40 years giving the world the best adherence measurement tool in existence. I consider it my privilege and my obligation to spend my next 40 years making sure that the world actually uses it, not for publications, not for conferences, but for the patient sitting in front of the pharmacist right now who deserves that system to see them clearly. Um, Predictive emergence, I want people to start looking at all three legs, not just the ones that show up in the data. And that's what the Adherence Project is all about. I want this to be an annual event and to really focus on not as a campaign, but as a movement, and then as an actionable thing where we're not just posting hashtags and one day, and then after that everybody goes on with the next celebration or event. But adherence is something that you have to do once, and then you have to do the next day, and then you have to keep on doing that every day. And especially with chronic diseases, they don't go away. You don't stop when you're getting better and say, hey, I'm healed, I don't have to take your medication anymore. No, it's the clinician's responsibility to say, hey, you're doing good, but adherence is a lifestyle. You got to really focus on wanting to see your grandchildren grow up, wanting to dance with your daughter on her wedding day. Smoking, alcohol, all these factors come into play. So you really want to focus on adherence, focus on healthier lifestyles, and continue to see your doctor annually. Those are the three things that I see. I want to emphasize in this platform, how we could look at healthier lifestyles. And that's another thing I want to talk about is there's certain places in the world we call blue zones. I actually think that we can actually help cardiovascular health improve people to become not mainly centenarians, but to live longer in life. And by doing what these blue zones actually focus on, whether it be walking daily, socializing more, eating healthier foods, if we do all that, we can actually help all of our places where we live to turn into blue zones or light blue zones or whatever zone you want to think of, but mostly live longer zones.
I like that, live longer zones.
Mhm.
But no, Philip, I just wanted to thank you as well. The work that your father has done and you've continued, it's been a great help to the healthcare community. Theresa and I, we follow your work, and it applies a lot to our work as well as things to consider when we're rolling out our interventions. Are we built properly on all three facets and domains versus just hammering down one domain? So that's an important takeaway for everybody. So we just wanted to thank you for taking the time and being here with us today. I'm excited. You're doing so much work. We're going to have a lot more podcasts. I'm hoping we can bring you back at some point just to talk about a little more progress and all the cool ventures that you're out on soon. And we get a cool update down the line on another episode. It would be great for us.
Yeah, 30 minutes is definitely not long enough to really go into my life
Yeah.
story. And like you said, definitely follow-ups are in order because, like I said, the Adherence Project is going to be here every year and it's going to keep on growing every year. And I'm going to be making new collaborations with kingdoms and with countries and with hospitals. And pretty soon the map's going to be all solid green because green means high adherence. And right now it's scattered between reds and yellows. So we want to move up, but the fact that people are using the system and contributing data, it's definitely a positive direction for us.
No, that's awesome. And for our viewers that want to know more or follow your work, what's the best way? Would you say LinkedIn, a website,
I
anything that
love
you want to
LinkedIn
shout
because
out?
I'm actually hitting a lot of the people who matter. But my website is www.adherence.cc. The platform is atlas.adherence.cc. And you can find me on LinkedIn, and I'm very open to communication. I love talking about this. Is my this is what I live for, and it helps me become a better person every day. So
Thank you so much for your time. I mean, seriously, we've learned a lot. We're excited to share this with everyone. And I know I'll be following you. So I'm looking forward to seeing how it goes next week for you. And then, of course, beyond that, too. But again, thank you so much for your time today. We really appreciate it.
and likewise, I appreciate this platform and reaching your audience, and cheering you guys on as well to help you grow.
Thank
Thank
you,
you.
Philip. Talk to you soon.
All right. Thank you.
Okay.